Now we're going to have a panel group discussing clinical governance and really leadership. And we, after a great deal of thought, we put together a very good panel for you to ask questions of and for us to ask questions of as well. So I'd like to introduce the panel members from, we're one chair short. That's my poor counting. So on my far left we have Dr. Ashley Bloomfield, who's the Acting Chief Executive of Capital and Coast DHB. On my right we have Matthew Ames representing Australia today. Down the far end was Gillian Bohm, who gave us that great talk before morning tea, is stepped in place of Ivona, and welcome Gillian. Dr. Nick Kendall is the Manager of Treatment Injury and Prevention Program with ACC and has been doing some work in collaboration with the Commission. Sheldon Ngatai is a Consumer Advisor on our Strategic Infection Prevention and Control Advisory Group for the Commission, also on the Ministry of Health Antimicrobial Resistance, or HARC it's called, working group, and a whole series of others, I'm sure. And Robyn Boyne is a clinical nurse specialist from Bay of Plenty District Health Board, and she's the current chairperson of the NZNO Infection Prevention Control Nurses College. So we have a question from the floor, but we also developed some questions to start this panel discussion off, which I hope will make you come up with some further questions. So the first question we had was for Nick Kendall, and it really was, how do you see New Zealand achieving a joined-up whole-of-systems approach to the prevention of healthcare-associated infections?
World Peace is next. World Peace is next.
Do you want to?
Yes, World Peace is next. So, shall I talk into this microphone? Okay, so, well, thanks very much. I think, actually, just reflecting what interesting discussion and topics have been covered already this morning. And I've kind of like got to that age now when I can say things like, just before I was born. Of course, the mass marketing and availability of antibiotics became available. My entire life, I've had the complacency of being able to rest on the ability of antibiotics to look after us. Obviously, my granny knew about things like cleaning wounds and washing hands and so forth. We seem to have forgotten a lot of that, and I guess at the moment there's a process of rediscovery. So in terms of coming together as a national solution, there clearly are really important things. And antimicrobial resistance, it still surprises me that we haven't yet managed to get good traction politically in New Zealand with this, despite the real importance of it. I would also say that it would be good, we've got at the moment quite a few professional groups that get together in the other areas that we're working in terms of patient safety and reducing patient harm. The other thing that's really clear is that we nearly always have solid consumer and advocacy groups, but in the infection area we don't have those really, and I guess that's something that I find quite interesting that could be very useful as well for us nationally. I think the other things that are really clear are that people at the coalface are trying their very best with limited resources, and the ability for those of us who are in central agencies to try and provide better tools and support for that is very important. And certainly that's one of the reasons why I've become a solid supporter for the ICNet surveillance platform, because I do think we've got an opportunity in New Zealand to do something that is national, that is joined up, and that actually provides us with something that most countries don't have. So I think those are the key things that I would say.
Thank you, Nick. Ashley, would you like to add to that discussion?
Yeah, thanks, Sally. Kia ora koutou. So Ashley Bloomfield, on my usual role as Chief Executive at Hutt Valley District Health Board, but I'm on loan to Capital and Coast at the moment. It's nice to see some colleagues amongst the the audience here. So the question as it was put to me was sort of how do you ensure a whole of systems approach, and Nick's talked about an element of that. And in particular, I'm interested in that accountability through the organisation. And I wasn't here for Gillian's presentation, but I had a quick look at her slides just to make sure I wasn't contradicting anything she said. Not worth doing. But I've sort of got and the definition of clinical governance here is really important, and I have great admiration for Liam Donaldson and Gabriel Scully. I've met them both. They're both much smarter than I am. But there's one element of their definition that I think is not explicit, and it should be because it relates to the genesis of clinical governance, which is about organisational accountability. It's not just being on this continual path of improvement, but it's about ensuring you can be accountable for clinical safety and quality right through the organisation, including up to the DHB board level in our case in New Zealand. So in my own definition of clinical governance, I'm really focused on that. Are we confident within the organisation we know what's happening and we can report up to the board level and provide assurance to the board, and they're accountable for that through the executive team? And what does that require? Well, it requires real focus, and it requires commitment at an executive level, but also at all those levels in the organisation. And a couple of other kind of working definitions I have. I think of the book by John Melgan, Report on Experience. It's sort of, it's one thing to read what definitions are, but how does that apply in your daily work? So a couple of other definitions that I use, one's around clinical engagement, and this is critical for getting anything to be a priority and making progress on it. And so I think of clinical engagement as being the sort of the formal and informal processes in an organisation whereby you engage clinicians in decision making, not in kind of having a contribution, but actually in decision making. And of course, what does that lead to? Well, that leads to the importance of leadership and clinical leadership across an organisation. And the reason I'm sort of belabouring this a bit is because this is what's critical to getting infection prevention control a priority within organisations. And so leadership, again, a working definition I have, and again, and I'm not contradicting anything Gillian said on her slides, but a lovely sort of kind of minimalist definition of leadership that I think about is ensuring direction. And of course, ensuring direction is different from giving direction. The latter is command and control. Ensuring direction is about convening and collaborating. And of course then if you convene and collaborate, your leadership's much more likely to be sustainable. So ensuring direction, generating energy, it's the other thing that leadership is all about, and that leads to focus and commitment. And so I just sort of put on the table that if we really do want to get this area shifted to another level as a sector, we need to be clear about accountability. We need to be clear about engaging clinicians and involving them in decisions right through our organisations. And third, about ensuring our leadership is convening, collaborating, generating energy, and we're getting focus and commitment at all levels of the organisation.
Thank you. We might just carry on and discuss these questions that we've got, but please feel free to be scratching down questions you want to ask about some of the discussion that's coming up now. So for Sheldon, I'm really interested to know how effective are our current DHB governance systems in supporting safe, effective and patient-centred goals for every consumer. And I'm going to ask Matthew a similar question afterwards if he's got some learnings from Australia that he might be able to share with us.
So, coming from a little province that's often not taken much notice of, there's a lot that needs to be done still, especially for the consumer being around the table. It has been something that the consumers have been banging on for some time, that they sit at that level of decision makings. And how do we actually change the culture of the thinking around engaging with consumers? We talked about that when Matthew answered my question earlier. I think we have to be really careful about when we do take on consumers, because many times it's by shoulder tapping. That can lead to problems of people not having yet come through their experiences. While that can be a good thing, it's also not a good thing, because they come with a certain bias because they're experiencing something not so good. and not being able to have the ability to actually come through and weigh up what was actually going on. But their questions and their experience is still very relevant to how change needs to happen. The consumer councils, many of the DHBs around the Motu have actually taken those on board. We're still waiting back in Taranaki. Not a lot of engagement happens for us back home about what should and shouldn't take place, which is really sad. So when you get this great divide still happening and we come together in a forum like this, we think to ourselves, for me in particular, sitting in amongst the expertise from the clinical position, how often do we as consumers have to keep coming to these things before our voice is actually heard? And I do believe that there needs to be a focus on making sure that when you do have the consumers around the table, that it's not that you remove those gatekeeping positions, because that's often what happens as well. You get the clinicians saying that we know what's best for you, rather than what clearly came out of Gillian's presentation is what actually matters for the patient. So until we actually start to look at engaging with consumers on the same level, we are your peers. And like with Matthew, when I first got involved as a consumer was actually with Central Cancer Network 9 years ago, and I was spoken to like the disease. I was diagnosed with breast cancer, and I had to stand up and say, oh, excuse me, but my name is Sheldon. So I was quite, it was quite heartwarming to hear Matthew say that himself, because that's often what happens. You're talked to as if you're not the person. Well, I am. And these are my experiences, the infections that happened, the process of how you were taken care of, the whole gamut. So, in answer to your question, a lot more improvement needs to be had, and I really do hope that what we see here today will be taken on much more.
Matthew.
Thanks, Sally. Thanks, Sheldon. I think I can't comment on the New Zealand system, but I probably can comment that everything that Sheldon mentioned happens in Australia as well. Certainly not alone. I think patient-centred care, I know the Australian Commission have certainly put a lot of guidance out on this particular matter. There is still a long way to go till that truly is part of the health system. I think we're still very much in the early days. And I think the question maybe to ask ourselves from a systematic perspective is nothing about us without us is probably one of the things that I really like to say. So when you think of this might challenge some of the DHBs, but on the board, is there an effective consumer voice when you're making decisions? I don't know the answer to that, but that's if you're really going to take and believe in patient-centred care, I think it needs to really start there. And I think what Gillian talked about around leadership and governance earlier, maybe just by way of a bit of a story, when I first became part of the executive team running the oil and gas business for Origin, I made a fairly career-limiting step. Pretty much my first meeting was as a new person onto that executive team. They turned to me and said, Matthew, you're new to the team. Give us your views on why our safety performance isn't as good as it could be. And I turned to them. The career-limiting step was, I hear you say safety is important, but I don't believe you. So, and they all kind of looked at me, and luckily I didn't get fired. And it ensued in a whole conversation around, okay, so what they were saying, they then looked inside and said, do I really believe this? And when you think of the leadership model that Gillian was talking about, we wouldn't be having this conversation if those who are in leadership positions, and I mean leadership broadly, including yourselves, truly believed that this was an important thing and that patient-centred care was a very important thing. we wouldn't be having this conversation. So from that cultural perspective, those beliefs must not be there, is my surmise. And so how do we challenge all of our leaders, when we hear them say things that are not congruent with the fact that we think they should believe? What I talked about my presentation, that parent who's looking after the kid, they're looking out for them. Similarly, how can we make sure that our leaders are doing the same thing? And the higher we go within the organisations, the bigger the influence was going to be. So if you have a board or a chief executive, sorry Ashley, who truly believes that this is a really important area, then that will flow through the organisation. I've seen it many scenarios. And as I said, it almost doesn't matter what you do. If you believe, you'll find a way, you'll find the best way. If something's not working, you'll fix it because you actually truly believe.
Thank you.
Just one more thing that I remembered as you were talking, Matthew. Ethnicity, equity and health literacy. 3 key points that need to be at the top of any agenda on how you're dealing with patients in particular. And just going back on an experience that I had becoming a consumer with CCN, and it was around the cancer nurse coordinator role. And that took roughly about 4 years to roll out from start to where we are now, which is fantastic because the whole initiative was adhered to for what patients were actually asking for, except for one thing, and it was the title nurse that got added into it. Because we, as those that were experiencing breast cancers, any form of cancer, we did not want to talk to another clinician. And long story short, our voices were overridden, and so that's how the cancer nurse became that role, which is unfortunate because today I still hear complaints of that service not going as we first anticipated it would be. So I just want to leave that with you.
Thank you both. I'm sure that's given you lots of thought about what questions you'd like to ask us, but our final question, really to set the scene for your discussion, is aimed at Robyn and Gillian, are really around how might DHB infection prevention control committees put structures and processes in place to support their IPC team delivery on a day-to-day operational issues, as well as maintaining the capability and capacity to participate in these national IPC quality improvement initiatives that we've got going. Robyn, would you like to start?
Okay, thank you. First of all, I wonder if that's the right question, how might infection prevention control committees put that, because in my DHB, the committee is a group of people made up from all the different disciplines that are in infection prevention and control. Mostly people, if they even come to the meetings, they come unprepared and they haven't read anything, even the chairperson. So they're all busy in their own roles coming to the committee, and we have these meetings and then they're gone. So it can be quite difficult. In many DHBs, we come under the infection control nurses come under different management structures. I think Jo Stoddart did some work in her dissertation last year, which showed that 40% of nurses, infection prevention control nurses, report to nursing, 40% to quality, and 20% to laboratory services. And some of them have just a single person in an organisation. Some have clinical nurse managers with a team under them. Some don't. Some have 2 or 3 different reporting lines, and we all report to different managers. So that makes it really difficult sometimes, to have this overall view of how the committee should actually work. So important, I think, is that obviously the terms of reference need to be clear and achievable, and there needs to be clear what the purpose of the committee actually is and who it answers to. So there can be varying layers between the Infection Prevention Control Committee and senior management, anywhere from 2 to 4 layers of different committees that one reports to one and it reports to another and it reports to another, do our messages even get to the hierarchy? So standardised templates obviously are probably a big useful. If you present too many graphs, they become meaningless. So the people reading them don't always understand what they mean. So, and obviously from our perspective, the reports that we write should not be onerous, so perhaps they should be less frequent. We're looking at perhaps having 3 monthly reports that show trends up more clearly. And we need to be able to demonstrate in a concise and clear way that we are fulfilling our terms of reference, and so the clinical indicators we use need to be relevant, but more importantly they need to show how collecting the data that we have makes a difference to patient outcomes. And so I'm really looking forward to hearing about the peripheral IV catheter talk next, because I think that's a really important one that we should be focusing on.
Thank you. Gillian?
Thank you, an interesting question, and one I think not only I see people but other people in organisations think about. I think if you go back to some of the things that we talked about in terms of leadership, I would advise 2 things, and I know this is difficult but we do, and that is to plan time in your day or your week for both reflection and for your leadership activities. And what should those leadership activities be focused around? Well, I think what I would advise would be the 4 key principles that we talked about around governance, and that is consumer and patient-centred. How has our work been in this last week, consumer and patient-centred? That we need an open and transparent culture. What have we done this week to ensure that that is happening, improving, maintained, that sort of thing, an open and transparent culture? We say of clinical governance, all staff participate and partner in clinical governance. Again, the work that we have done during this particular reflective period, what have we done to ensure that all staff are able to, if necessary, participate? And, of course, a continuous quality improvement focus.
Thank you, Gillian. Now, there's been some very interesting comments made, so I know a number of you will be Twitterers. So there is the hashtag up there, so please tweet out our messaging so that people that are not here can hear about what's going on. We have a question from the floor, and thank you, Catherine O'Hara, which I'm going to put to the group. And the question is really, what is the value of clinical governance versus shared governance, or is it the difference between clinical governance and shared governance? Do you want to start with that, Gillian and Ashley, and comment on that?
Thank you. Well, thanks for the question. The idea of governance, of course, is around oversight and accountability. And, I want to pick up the point Matthew made, and there's no need to apologise to me as the DHB Chief Executive, because the point I want to make here is maybe we need to move to a definition of clinical governance that is more inclusive, because the clinical bit makes it sound exclusive. And the emphasis I was trying to put on my definition is about accountability at all levels of the organisation, and at the board level, they should be assuring themselves that there is appropriate consumer involvement right through the organisation at appropriate places. And Sheldon referred to the establishment of consumer councils, or Cape Coast we're calling it a citizens council, and it's designed to provide that advice right at the board level, but that should be just one expression of that. So yeah, maybe it's a good time for us to rethink the definition of clinical governance, and whether we relabel it shared governance. I think, give it a more inclusive nature, but it is about that accountability.
Gillian?
Thank you. I think it is an interesting question, as Ashley said. I think that from my perspective, I would think that one of the values of any clinical governance system would be about shared governance. And at the heart of our framework, we have talked about the 3 people that we see really important here, and there's consumers, managers and clinicians, which is at the heart of our framework. And so we do that. And there are many, during the course of us developing the framework and doing it, the discussion about whether clinical governance was a term we should use or shouldn't use, or should we call it something else, was one of the things we consulted on quite a lot. And we had everyone in a broad diversity of views, from people in the sector said, if you put that clinical governance and Scully definition on it, it'll die before an early death, to other people who said, well, yes, we certainly could find another definition, but then we would sort of be out of kilter with the rest of the world and the rest of the way people think. And so we opted for continuing to call it clinical governance, but then working on a framework that is really different from other countries. The first thing about it is we say consumers are at the heart of it, and I can assure you from looking at all other frameworks that there's no mention of consumers in any of the other frameworks in any of the jurisdictions. So I think that, and I think if you look at the 4 components that are in our framework, the first one's about engaging consumers and patients. The next one's about clinical effectiveness. The next one's about quality improvement and patient safety, and then engaging and having an effective workforce. And I think that shows that this is a system-wide framework that we need, and it is about sharing there. And the governance word, well, it's sharing lots of things. It's improving the culture, sharing the data, ideas, working on innovations, those sorts of things. So my proposal would be that a good clinical governance structure is shared governance.
Great. Do you have anything to add, Matthew?
Probably just a reflection from other industries is, I'm on a board that is in the healthcare sector, and the word clinical governance was very foreign to me. I'm used to just talking about governance, and that includes everything. Now I realise sometimes that can be construed as just looking at the money or the finances side of things, but we all know the finances affect the quality as well. So, for me, it's just good governance, and you need to look at the holistic picture of the organisation to make sure you're delivering a very good outcome, which is at the fundamental of what the clinical care definitions give anyway. So that's probably my only feedback.
Any of the other panel members wish to contribute?
Well, I guess I could just say, I suppose that means we should be perhaps looking at having consumer involvement in our infection prevention and control committees, which I think is something that's perhaps new to us, because that's consumers do see things from a very different perspective.
The only thing, Sally, for me is that what the word clinical infers. So when you're thinking about putting the patient at the centre of what you're talking about, and you've got the terminology clinical there, you're naturally always going to have that bent. So for me, I'd rather see the word clinical gone. Governance kind of like sums it up really. I don't think there's any shared what Gillian said, but anything but clinical, because I think it kind of like drives the way the thinking happens.
Can I add
Yep.
something as well? I agree with all my colleagues. However, the word safety hasn't really been mentioned except by Matthew, and I think clinical governance has a very important part to play, to be thinking about risk and choices of risk. And in actual fact, while I suspect everybody does that, they don't necessarily do it explicitly or think about it. But clearly, because we're talking about multi-causal and complex scenarios, that is certainly something that is well worth sharing. And I think that's where it ties in so strongly with the consumer point of view. When I'm a consumer of healthcare, I like to know about risk, and I like to actually be part of the decision about whether I want to take a risk or not. And I think that's entirely appropriate. And again, it comes back to the phases of healthcare. I don't just want to tackle medicine. I always think in a maximum of 3 dot points, because I spent most of my academic life with orthopaedic surgeons, and if you give them 4, they can't go any further. But we have come from a period of omnipotence And we are currently trying really hard to move into a period of shared decision making. But ultimately, we will give over power from healthcare to consumers and also to our societies. I mean, there's a lot of ethical issues as well that are continuing to arise and getting more complicated, and they're not going to be solved or defined easily just by a bunch of clinicians sitting around a table. So that would be my thoughts.
Thank you, Nick. So we've got some questions from the floor. Thank you very much. So from Dr. Joe Bourne, who's the Clinical Director of Innovation and Improvement at Bay of Plenty DHB. Based on Ashley's comments about clinical engagement and involvement in decision making, how do you, Ashley, measure this? How do we know we are doing well or if we need improvement?
Well, I could quote from that famous Australian movie, The Castle, and say, well, it's the vibe of the thing, but that probably wouldn't satisfy the audience. Look, I don't have a clever answer to this. I think we should be perhaps a bit more methodical about how we measure that. But again, I think just to go back to what I was talking about, which is actually formal and informal involvement in decision making. So we should be looking at our key decisions in our organisations as they relate to anything, but in this case we're thinking about infection prevention control, and be looking at an executive and a board level as to how clinicians were engaged. And I think it, based on the discussion here, and its opposite, is how were consumers engaged in those decisions. And that's why I think you'll have seen DHB setting up not just consumer councils, but many also setting up clinical councils as part of that formal clinical engagement process.
Great, thank you. Tim, do you want to, we've got roaming microphones, or would you like me to read it out? Okay, so Tim Blackmore is infectious disease physician, clinical microbiologist at Capital Coast, DHB, and he really says, aren't we all consumers ourselves directly or via loved ones? Why is there this dichotomy? I'm going to pass it on to you two.
You start from New Zealand perspective.
Yes, we are, Tim, very much so. Everybody in here benefits from the health system. The difference is that it is difficult for a clinician to come from an unbiased perspective and have that objective around a consumer view. That's how I see it, that's how many of the other consumers see it, and we just feel that it's impossible for a clinician to be able to give that perspective unobjectively.
I have to say I strongly disagree.
Yeah, of course.
We'll leave that disagreement discussion for lunch.
Yeah, I don't disagree. We are all consumers. And I think it's what we can all bring to the table that is very important. And I think Sheldon's point is also valuable, that when you actually think of pulling a team together, be it a board or be it any team, it's actually the diversity that team brings that will actually make it stronger. So I think when actually making those decisions, about a group of people, do we have the right amount of differing views or different diversity that actually is going to make that decision better? I think is the question that we actually need to ask. And I think in many scenarios, there is value in finding consumers that are relevant to that particular area that will provide that diversity of thought. And it might be diversity from, deviating from a clinician's perspective, or it might be actually, more in-depth engagement with the system, which actually brings that insight out. And we all have different stories. Mine is that I've probably seen about pretty much every specialist there is to see, apart from a gynaecologist and obstetrician. They haven't quite worked out how to get a referral for that yet. But with that, I've been scanned, I've gone to probably, 15 hospitals across multiple jurisdictions and internationally. I can bring to the table how my surgery went in Chicago and bring that to the table. So there are different perspectives, and different people are going to have different perspectives to me. And I think it's just about asking that question, how do we get that right diversity of thought into that question that we're actually trying to make a decision on?
Thank you very much for that. With this run out of time, and I think the panel discussion has been excellent. Some of the members of the panel will be here at lunchtime to continue the discussion, so I'm sure they won't mind. Or even from the Commission's point of view, if you wish to provide us with some feedback around this panel, we'd be very interested to hear that. So while my panel members all are discharged of their duties, leave the stage, you can all get your phones out and tweet. We want to have a presence, so you need to tweet and get your 10, I've got 50 followers. They will retweet and might give us a presence at this meeting. Thank you, Matthew.